Ever feel like you're facing a medical mystery? Like you're in one of those intense exam rooms, and suddenly a patient presents with a whole bunch of puzzling symptoms.
Oh, absolutely.
Well, today we're diving deep into a collection of real MRCP PACES cases.
Yeah.
It's like cracking open those tricky patient presentations and really getting into the nitty-gritty of how doctors diagnose these things.
That's the exciting part, isn't it?
Welcome to the Deep Dive, where we take a look at complex medical source material and pull out the key pieces of information you really need to know.
It's all about those golden nuggets.
And a huge thank you to London HeartbeatsZ Academy UK for giving us these awesome case studies.
Yes, definitely.
And to all you future doctors out there, don't forget to hit that subscribe button on our Facebook, Instagram, Spotify, and YouTube channels for more deep dives like this one.
We'll keep them coming.
So let's jump right into our first case.
All right, let's go.
We've got a gentleman who's come in with tongue fasciculations, those little involuntary muscle twitches, and he's specifically here for a cranial nerve examination.
Interesting. So right off the bat, we're thinking about the hyperglossal nerve.
The 12th cranial nerve, right?
That's the one. It controls tongue movements. So we need to figure out if any other cranial nerves are involved.
And there's more to the story. On examination, he shows weakness of the soft palate.
That suggests the vagus nerve is involved.
The 10th cranial nerve.
Right. And to make things even more interesting, he also has nasal speech.
This is where it gets tricky, right?
It does. These extra findings narrow down our possibilities. Motor neuron disease immediately comes to mind, either bulbar or pseudobulbar palsy.
How do we even tell those apart?
Well, in bulbar palsy, you'd see muscle wasting and weakness in the muscles controlling speech, swallowing, and tongue movement.
Okay.
Pseudobulbar palsy, though, that's caused by damage to the pathways connecting the brainstem to the cortex. So you get exaggerated reflexes, emotional ability, and difficulty controlling facial expressions, along with the speech and swallowing problems.
All right, so it's all about those subtle differences in how the symptoms present.
Exactly. It's those nuances that matter.
So what other conditions should we keep in mind here?
Well, syringomyelia is another important one to consider. It's a condition where a fluid-filled cyst forms within the spinal cord.
Wow.
And that can impact the lower cranial nerves. It can present with fasciculations, muscle weakness, and even dissociated sensory loss.
So we should be looking for sensory abnormalities too.
Absolutely. Now, Guillain-Barré syndrome could also cause weakness and nasal speech.
Right.
But it's less likely in this case. Guillain-Barré usually presents with more widespread weakness, often starting in the legs and moving upwards.
Okay.
You might also see absent reflexes. The lack of obvious muscle wasting and the potential for eye muscle involvement also makes it less probable.
So taking everything into account, what's the most likely diagnosis for this gentleman?
Based on what we've discussed, it's most likely bulbar palsy due to motor neuron disease. It's a serious condition with a big impact on the patient's quality of life.
Now for case 2, we have a diabetic female patient presenting with skin lesions. What jumps out at you about her demographics?
The fact that she's both diabetic and female is a big clue.
Oh.
It really points us towards certain conditions.
So what about the lesions themselves? What makes them stand out?
These lesions are described as well-circumscribed papules or nodules, meaning they have distinct borders. They start as red-brown, but over time they change.
How so?
Well, they expand and the center becomes waxy, atrophic, and yellowish. You're left with a plaque in the center while the borders stay active. It's a pretty unique pattern.
So what diagnosis are you leaning towards?
This sounds like a classic case of necrobiosis lipoidica diabeticorum, or NLD for short. It's rare, and it mainly affects women with diabetes.
Ah, so it's directly linked to diabetes, particularly in women.
Yes. Now, at the tissue level, NLD is basically a disorder of collagen degeneration.
Collagen being that protein that gives structure to our skin.
Exactly. And in this case, it breaks down, which then triggers an inflammatory response. The blood vessel walls thicken, and you get fat deposition.
And these lesions can show up in other places too, right? Not just the shins.
That's right. You might see them on the scalp, trunk, and upper extremities. So a good skin exam is really important.
Makes sense. And of course, we need to check her urine for glucose given her diabetes history.
Absolutely. Always a good idea.
All right, case 3 throws us a bit of a curveball. It just says, examine the patient's neck, no other details. What are we supposed to do with that?
That's a classic MRCP move. It usually means they want you to focus on assessing thyroid status.
So we need to be ready to show off our thyroid examination skills.
Exactly. And remember, the exam question could be phrased in different ways. You might be asked to assess the patient's thyroid status directly, or they might say something like, "This lady complains of tremors. Would you like to examine her?"
Oh, I see. So how should we approach this systematically?
First, you want to show how you'd evaluate thyroid function. That means checking for a tremor, taking their pulse, noting any sweaty palms, and looking for thyroid eye signs.
Thyroid eye size.
Yeah, things like ophthalmoplegia, where the eye muscles are weak, and changes in reflexes.
Got it. So we're looking for those systemic signs of thyroid issues. What's next?
Then you move on to palpate the thyroid gland itself, describe its size shape, and any nodules or tenderness.
Okay.
But here's the crucial part. You always want to check for retrosteral extension. That's where part of the thyroid gland extends behind the breastbone. Also, listen for a thyroid bruit.
A what?
A bruit. It's a whooshing sound caused by increased blood flow to the gland.
Interesting. And anything else we should have missed?
Don't forget to look for signs of proximal myopathy. That's muscle weakness in the shoulders and hips, and pertibial myxedema, a thickening of the skin on the shins.
Wow. So many little details to keep in mind.
It's all about connecting the dots.
Now, cases 4 and 5 both involve examining the patient's hands, but they don't give us much to go on. It's a bit daunting.
I agree. But case 5 gives us a little more to work with. It's actually described as a gift in the MRCP PACES exam. So pay attention here. The main thing to notice is a bilateral symmetrical deforming polyarthropathy, affecting the small joints of the hands, particularly the PIP and MCP joints.
Okay, so that symmetrical involvement is a big clue.
It is. It points us towards systemic conditions like rheumatoid arthritis and psoriatic arthropathy.
Both of which can cause those joint deformities. How do we tell them apart?
With psoriatic arthropathy, you'd expect to see nail pitting, those little depressions in the fingernails, as well as skin lesions and that telescoping of the fingers.
Like playing detective looking for those subtle hints.
You got it.
Huh.
Now, even though long-term high-dose steroid use isn't typical in rheumatoid arthritis, it's worth looking for signs of Cushing's syndrome, just to be thorough.
Good point. And how important is it to assess the patient's functional status in these cases?
Oh, it's essential. You want to observe simple things like them holding a key to test their pincer grip,
Okay.
or unbuttoning clothes to assess hand function, and combing their hair to check for shoulder involvement.
So we're getting a real sense of how this condition impacts their daily life.
Exactly. Now, don't forget to examine other joints for involvement, too. These conditions aren't limited to the hands. Also, look for splenomegaly, an enlarged spleen, which could point towards Felty's syndrome in rheumatoid arthritis. And check for lower lobe fibrosis in the lungs.
It's all about that big picture view.
Absolutely. So for case 5, what do we think?
Sounds like rheumatoid arthritis.
You nailed it. She's being treated with methotrexate salazopyrene and a low dose of prednisolone.
That's a pretty intense combination.
It is. And remember, rheumatoid arthritis is an autoimmune disease. So it's often associated with other autoimmune conditions like Sjogren's syndrome and autoimmune hepatitis.
It's amazing how interconnected everything is.
It really is.
Now, case 6 takes us into a more sensitive area, breaking bad news.
Oh, yeah, that's never easy.
In this case, we meet Mr. Lee, a 55-year-old man who's had chronic hepatitis B for years. He's been experiencing right hypochondrium pain for about a month. His GP has been following him with yearly alpha-fetoprotein tests and abdominal ultrasounds, which have all been normal.
Okay.
But then a recent CT scan showed something much worse.
What did they find?
The CT showed an advanced hepatoma with lung metastasis. The consultants don't think there are any curative treatment options, just palliative care.
Oh, wow. That's tough news to deliver.
It is. Breaking bad news is never easy. How do you even approach those conversations?
It takes a lot of empathy, clarity, and a genuine connection with the patient. In MRCP PACES exams, you'll often face scenarios where you have to break bad news, either about chronic illnesses like SLE motor neuron disease, multiple sclerosis, Parkinson's disease, or dementia.
Right.
Or about advanced cancer.
What kind of questions should we expect from Mr. Lee?
Oh, be prepared for anything. Am I going to die, doctor? Are you sure about the results? They might plead with you to save them or refuse to tell their families. You need to create a safe space for them to process everything.
That sounds incredibly challenging for everyone involved.
It is. But by being present listening and offering support, we can help guide them through it.
All right, moving on to case 7. We meet another patient with double vision. It's like neurology is a common theme here.
It is. And remember, always start by shaking the patient's hand.
Such a simple but powerful gesture.
It helps build rapport. Then you move on to a thorough general inspection. Look for anything unusual from their facial expressions to their gait posture and overall appearance. In this case, pay attention to things like frontal baldness, a flat or expressionless face, which could mean muscle wasting and bilateral aptosis.
Drooping eyelids.
Exactly. Now, what's the diagnosis for this case?
Let me think. This patient has ocular myasthenia gravis, right?
You got it. It's a condition where the immune system attacks the muscles controlling eye movements, leading to double vision, drooping eyelids, and trouble maintaining upward gaze.
So how do we confirm that diagnosis during the exam?
You want to demonstrate fatigability? Ask the patient to look upward and count. Watch for any drooping of the eyelids or if they struggle to keep looking up.
I see.
You can also ask them to repeatedly flex and extend their shoulder to see if fatigue makes their symptoms worse.
Clever ways to test those muscles. What else should we keep in mind?
Some medications can trigger a myasthenia crisis, so be familiar with those. Also remember, diabetes mellitus, which can cause pitosis, is inherited in an autosomal dominant pattern. And be ready to discuss other associated symptoms like cataracts, diabetes itself, and even heart block.
Okay, so even a seemingly simple presentation can have complex underlying connections.
That's the beauty and the challenge of medicine. Unraveling those connections is key.
Okay, case 8 gives us a gentleman with a history of recurrent PR bleeding. But again, very little information. Just examine the patient. What do we make of that?
It's another one of those cases where you have to show off your clinical detective skills. Based on the recurrent PR bleeding, the likely diagnosis is hereditary hemorrhagic telangiectasia.
Oh, wow. That's a mouthful. What is that exactly?
It's also known as Rendu-Osler-Weber disease. It's a genetic condition that causes abnormal blood vessels.
Okay.
These blood vessels are called telangiectasias, and they can be found in various parts of the body, including the skin mucous membranes and internal organs.
So are they dangerous?
They can be because they bleed easily. This can cause a whole range of problems, from nosebleeds to gastrointestinal bleeding, and even bleeding in the lungs or brain.
So it's not just a minor inconvenience.
Definitely not. How do we manage this condition?
Well, I imagine controlling the bleeding is crucial.
Absolutely. You're right. Treatments like estrogen therapy or cauterization, which seals off those bleeding vessels, are often used.
Okay.
But patient counseling is equally important. They need to understand the potential risks, especially if they're thinking about having children, because it is a hereditary condition.
It's a good reminder that good medical care involves more than just treating the physical symptoms.
Exactly. It's about the whole person.
Now, case 9 highlights something that can be uncomfortable for both doctors and patients taking a detailed sexual history.
You're right. It's a sensitive topic, but so important.
Absolutely. This case emphasizes how crucial it is to approach these conversations with sensitivity, respect, and a non-judgmental attitude.
Otherwise, you risk missing a crucial diagnosis.
So what kind of scenario are we talking about here?
Imagine a young patient comes in with a bunch of vague symptoms that could point to many different things.
Right.
Things like thyroid problems or inflammatory bowel disease. But they're hesitant to talk about their sexual history.
I can see how that would lead to delays in diagnosis.
And those delays can have serious consequences. There have been cases where a missed opportunity to get a complete sexual history resulted in a delayed HIV diagnosis.
Wow.
And that can have devastating effects on the patient's health and well-being.
It's a stark reminder that even those difficult conversations are essential for good medical care.
Absolutely. Now, in case 10, we have a gentleman with purplish striae on his abdomen and upper thighs.
Those stretch marks are a classic sign of Cushing's syndrome, right?
You're right. This is a common case in the MRCP endocrine substation.
So what else should we be looking for?
Look for other signs of Cushing's syndrome, like a buffalo hump, a moon face thinning skin with easy bruising, excessive hair growth, and acne. Don't forget to check for proximal muscle weakness and tenderness along the spine, too.
So we're basically running through a Cushing's checklist.
Exactly. And then you want to suggest some further investigations. Check the patient's urine for glucose, measure their blood pressure, and ask about any history of long-term steroid use.
We're leaving no stone unturned.
And examine the abdomen for any surgical scars, too. They could be related to previous treatments.
What's the conclusion for this gentleman?
He has Cushing's syndrome secondary to long-term steroid use. Apparently, he was admitted due to fulminant sepsis with an Addisonian crisis.
A lot going on there.
It is. So the takeaway here is don't stop at diagnosing Cushing's syndrome. You need to figure out what's causing it, whether it's the steroids, a tumor, or something else, and be aware of those potential complications like infections and metabolic problems.
Okay. In case 11, we meet Mrs. Lydia David, a 70-year-old retired teacher experiencing jerky movements in her right hand. She also has a history of diabetes. A neurologist believes she has Parkinson's disease.
So this case isn't about making the diagnosis because we already have it. It's all about communication. You're the SHO explaining this life-changing diagnosis to Mrs. David.
It's a good reminder that being a doctor isn't just about knowing the science. It's also about clear and compassionate communication.
Absolutely. Now let's move on to case 12. We're back to a patient with double vision. It seems to be a recurring theme in these neurology cases.
It does, and I bet you're going to tell me to start by shaking the patient's hand.
You know me too well. It's all about building that connection. What does the exam show in this case?
It reveals left-sided poo cysts.
So drooping eyelid, we need to think about what's causing it.
Right. We've seen ptosis before in a few different scenarios.
Yeah.
What are our main considerations here?
We need to think about the nerves and muscles that control eyelid movement. If we suspect Horner's syndrome, which can cause ptosis, we need to look for the underlying cause. Check the neck for any abnormalities, examine the lungs for a Pankos tumor, and assess the cervical spine for signs of syringomyelia.
So we're not just focusing on the eyelid, we're looking for clues elsewhere.
Exactly. Now, if we suspect third nerve palsy, we need to look for involvement of other cranial nerves.
Okay.
And if it's an isolated third nerve palsy, meaning only the third nerve is affected, then diabetes mellitus is the most likely culprit.
Diabetes seems to be popping up a lot in these cases.
It does. It affects so many different systems.
Yeah.
Now, how do we tell the difference between a medical and a surgical third nerve palsy?
Good question.
The pupil is key. In medical third nerve palsy caused by things like diabetes or hypertension, the pupil is usually normal size. But in surgical third nerve palsy caused by pressure on the nerve from an aneurysm or tumor, the pupil is usually affected and might be dilated or fixed.
So pupil gives us a vital clue.
Exactly. What's the diagnosis for this patient?
Based on the findings, it's likely left-sided, isolated third nerve palsy due to diabetes.
Right. Again, anything else worth mentioning for this case?
What about those tricky examiner questions?
Oh, they might ask you about the reason for pupil sparing in medical third nerve palsy. Make sure you can explain the physiology behind it. And remember, unilateral proptosis, a bulging of the eye, can sometimes mimic cassavotosis, so keep that in mind.
Always good to have a broad differential. Now, case 13 takes us back to a simple instruction: examine the patient. No specific details, just examine.
These cases can be tricky because you have to rely on your own clinical skills to guide you.
A true test of our abilities. What's the diagnosis in this case?
This lady has hypothyroidism, probably secondary to a previous total thyroidectomy.
Meaning her thyroid gland was surgically removed.
Exactly. Now, this specific scenario might not be super common in PACEs, but hypothyroidism itself is quite prevalent, especially in older adults.
So it's something to always consider, particularly in older patients with those non-specific symptoms like fatigue and weight gain.
Absolutely. And remember, previous total thyroidectomy is the most common cause of hypothyroidism.
Okay, case 14 brings us another lady with a moon-like facies and multiple vasculitic rashes on her hands. Sounds familiar.
It does. Cushing's syndrome is a popular topic in MRCP PACEs, so expect to see it a few times.
All right, let's go through that Cushing's checklist again. What are we looking for?
Look for that buffalo hump, hirsutism, supraclavicular fat pads, purplish stray, proximal muscle weakness, and spinal tenderness. You'll want to check her blood pressure, examine her urine for glucose, and even assess her visual fields.
Okay, we're being thorough. What about those vasculitic rashes? What do they tell us?
Vasculitic rashes are often linked to autoimmune diseases, so it suggests there might be something more going on here.
Like what?
This lady actually has Cushing's syndrome, but it's secondary to long-term steroid use for lupus nephritis.
Ah, so the rashes were a clue pointing towards lupus.
Exactly.
Right.
And this case shows how important it is to look beyond the obvious diagnosis. Don't just stop at Cushing's syndrome. Investigate the underlying cause and any contributing factors.
So for Cushing's syndrome, we need to think about those different potential causes.
Right. Things like long-term steroid use, pituitary adenomas, adrenal adenomas or carcinomas, and even tumors elsewhere in the body that produce excess hormones.
There are a lot of possibilities.
There are, and make sure you're familiar with the tests used to confirm the diagnosis and find the underlying cause. Things like 24-hour urinary-free cortisol dexamethasone suppression, tests, plasma ACTH levels, and imaging studies.
It's complicated.
It is.
Okay, case 15 asks us to examine a gentleman's abdomen. Not much to go on, just examine. What should we be focusing on?
Start with a good inspection looking for any scars, distension, or discoloration. This gentleman has a scar in his right lumbar region, suggesting he's had surgery.
Okay.
Palpation is also key. Note the size and consistency of his liver and spleen, check for any masses or tenderness, and feel for his kidneys.
Thorough as always. What else are we looking for?
This case highlights the importance of looking for side effects of long-term immunosuppressant use, especially in transplant patients.
Oh, I see. The scar suggests a possible kidney transplant. What specific signs should we look for?
Look for signs of Cushing syndrome, which can be a side effect of those corticosteroid medications. Also look for gum hypertrophy and jaundice, which can be caused by certain immunosuppressants like cyclosporine and azathioprine.
Those seemingly minor side effects can actually reveal a lot.
They can. Now, to assess the function of the transplanted kidney, you'll want to consider a few things.
Like what?
Check his 24-hour urine output. Good volume suggests good kidney function. Then gently palpate the transplanted kidney, feeling for tenderness, which could mean rejection, although that's less likely with immunosuppressants.
Okay.
Listen for a renal bruit, that whooshing sound that could mean artery stenosis, and examine his arteriovenous fistula, or AVF.
So if there aren't any recent puncture wounds on the AVF, it means the transplanted kidney is doing its job.
Exactly. You got it. So for this gentleman, the conclusion is a functioning transplanted kidney. He's on cyclosporin, prednisolone, and azathioprine, which are probably causing the gum hypertrophy and hypertension.
It's amazing how much we can learn from a thorough examination.
It really is all about connecting the dots. Now let's talk about some key points for managing patients on immunosuppressants.
Sounds good.
You need to know the common side effects and potential interactions of those medications. For example, cyclosporin can cause kidney damage, high blood pressure tremors, gum overgrowth, elevated uric acid and potassium levels, weight gain, diabetes, acne, and low magnesium levels.
Wow, that's a lot.
It is. And there are also food and drug interactions. Grapefruit juice, Mediterranean oranges, and even a certain citrus soda can enhance the effects of cyclosporin, while St. John's wort, an herbal supplement, can reduce its levels.
So many things to consider.
There are. What about other common immunosuppressants?
Tell me more.
Well, azathioprine can suppress bone marrow function and cause a drop in blood cell production. It can also cause cholestatic jaundice and gastrointestinal upset. And it's worth noting that it can cause irreversible bone marrow failure in people with a specific genetic variation.
Oh, wow.
But there's a DNA test to identify those at risk.
That's amazing.
It is.
Yeah.
Now, prednisolone can cause Cushing syndrome, and mycophenolate can lead to gastrointestinal upset, headaches, and bone marrow suppression.
Managing these patients is a real balancing act.
It is. It requires careful monitoring, patient education, and a good relationship between the doctor and patient.
Okay, K16 throws us back into a general examination scenario. This lady has a rooftop scar, a horizontal scar on her left side.
Okay.
Further examination shows jaundice and an enlarged liver, but no signs of chronic liver disease. This is interesting. What are you thinking?
That rooftop scar is a big clue. It suggests she's had a splenectomy.
Her spleen was removed.
Right. And the jaundice and enlarged liver without signs of chronic liver disease point to a condition that requires frequent blood transfusions.
I'm starting to see the connection. Those transfusions can cause iron overload, which can then damage the liver.
Exactly. What else should we look for?
What about scars from those iron chelation treatments?
You're on the right track.
Mm.
Look for multiple small scars on her abdomen. They could be from subcutaneous infusions of iron chelation therapy.
So what's the diagnosis?
This lady most likely has thalassemia major. It's a genetic blood disorder that causes severe anemia. So these patients need regular blood transfusions, which leads to iron overload and sometimes the need for a splenectomy.
That's a lot to deal with. What are the key things to remember when managing these patients?
Management involves regular blood transfusions, iron chelation therapy, and monitoring for complications like infections, heart problems, and bone abnormalities. Sometimes they need a splenectomy to reduce the frequency of those transfusions.
So given the iron overload, what else should we assess?
Check for signs of hypogonadism, growth retardation diabetes, and hypothyroidism. Also take a good family history since thalassemia is genetic.
It's a complex condition.
It is.
Okay, before we wrap up this part of our deep dive, let's take a look at case 17. We have Mr. Letterman, a 56-year-old man complaining of lethargy for the past 3 months. He's had a bunch of tests, but they've all come back normal. He has a history of gastritis and diabetes.
Lethargy is such a common complaint, but it can be really tricky to diagnose.
It's so vague.
It is. Before we jump into the exam, we need to consider all the possibilities.
Okay, so what are some of the things that could be causing his lethargy?
It could be something simple like anemia or hypothyroidism, or something more complex like depression, myasthenia gravis, or obstructive sleep apnea.
So we need to keep an open mind.
Absolutely. How should we start when we meet Mr. Letterman?
Well, we need to figure out what he actually means by lethargy.
Exactly. Ask him to describe his symptoms in detail and see if the lethargy is worse at any particular time of day. That can be a helpful clue. For instance, people with myasthenia gravis often feel more tired as the day goes on.
So a detailed history is crucial.
It's our most valuable tool.
And with that, we'll conclude part 1 of our deep dive. Make sure to tune in for part 2, where we'll continue to explore these fascinating MRCP PACES cases and uncover more clinical pearls and exam tips. A big thank you again to London Heartbeats Academy UK for providing these insightful case studies. And to all our listeners, don't forget to subscribe to our channels on Facebook, Instagram, Spotify, and YouTube for more deep dives like this one. We'll see you in our next deep dive.
See you there. Welcome back to the deep dive.
Ready for more MRCP PACES cases?
Absolutely. Let's jump into case 18. We're asked to examine a patient's hands, and the picture shows some pretty striking deformities.
I can imagine that could be a bit intimidating in an exam situation.
It's definitely designed to test your ability to stay calm under pressure.
So how should we approach this case?
Don't panic. Stick to the basics of a good locomotor exam. Inspect, feel, palpate, assess passive movement, do a functional assessment, and any special tests. And remember, in the locomotor exam, we don't shake the patient's hand.
No handshakes.
Yeah.
Got it. What do we do first?
Start by asking the patient about pain, any specific joint that's really bothering them. Then ask them to rest their hands on a pillow just to relax the muscles.
Makes sense. So what are we looking for during the inspection?
You want to describe any abnormalities you see, whether it's deformities, muscle wasting, or anything else that stands out. Look at both the palms and the backs of the hands. Pay attention to the nails, too. Check for pitting.
Okay, so those little depressions in the nails.
Exactly. And gently feel the skin, see if there's any warmth, which could suggest inflammation.
Okay, so we've inspected. What's next?
Palpation and passive movement. Gently palpate each joint using passive movements to assess the range of motion. You're feeling for any synovial thickening or tenderness.
Which would indicate inflammation.
Right. Also check for signs of scleroderma, feel for calcinosis, and tap the flexor retinaculum for carpal tunnel syndrome.
So much information just from examining the hand.
Absolutely. Now we move on to functional assessment.
Right, because we want to see how this actually impacts the patient's daily life.
Exactly. Observe them doing things like stepping, unbuttoning their clothes, and picking up a key to assess their pincer grip. And if you think the elbow or shoulder joints might be involved, ask them to comb their hair.
Okay, so we've gathered all this information. What's the diagnosis in this case?
Based on what we've seen, especially the nail pitting, this lady has psoriatic arthropathy.
Psoriatic arthropathy, so that's the joint problem that can go along with psoriasis, the skin condition.
That's right. And there are different types of psoriatic arthropathy, so it's important to be familiar with those.
Okay, good to know. Let's move on to case 19. This one is about prosthetic heart valves.
A very common topic in MRCP exams. Be prepared to discuss the complications.
Like what kind of complications?
Well, with mechanical valves, you have complications related to the valve itself. Things like dysfunction, hemolysis, and endocarditis.
Right, endocarditis, that's the infection of the heart lining.
Exactly. And then you have complications related to the treatment, specifically warfarin.
Because they need warfarin to prevent blood clots.
Yes, but that comes with a risk of bleeding.
What other questions might they ask about prosthetic valves?
They might ask about causes of anemia in a patient with a prosthetic valve, or they might ask you to differentiate between different types of valve.
All those tricky distinction questions.
Exactly. Or they might ask you to assess whether the valve is functioning well just by listening to the heart sounds.
Okay, so it's really important to understand the different types of valves and their unique sounds.
It is. Now let's move on to case 20. This one involves a patient with erythema ab igne.
Erythema ab igne, what is that?
It's sometimes called fireplace rash or toasted skin syndrome.
I can see why. So what causes it?
It's caused by prolonged exposure to heat.
Like sitting in front of a fireplace?
Yes, or using heating pads, laptops, or even hot water bottles for too long.
So what should we be looking for?
Obviously, the rash itself is usually quite distinctive, but you should also check for signs of hypothyroidism. And always consider the possibility of an underlying malignancy, especially if the rash is widespread.
Okay, so look beyond the obvious.
Exactly. Now, case 21 brings us a patient with livido reticularis.
That's that mottled purplish discoloration, right?
Yes, it creates a net-like pattern on the skin. It's often associated with SLE.
SLE, that's systemic lupus erythematosus, the autoimmune disease.
Right. And as with erythema ab igne, you need to look for other signs of SLE and always consider the possibility of malignancy.
So we're looking for that bigger picture again.
Absolutely. And examiners might ask if livido reticularis can be a normal finding. It can be seen in some healthy individuals, particularly young women, especially when it's cold, but you always need to rule out anything serious.
It's about context, isn't it?
It certainly is. Now, for this particular case, the lady does have livedo reticularis due to SLE. And remember, although it might not be a popular exam question, livedo reticularis is often missed by candidates. So pay attention to the skin.
Good advice. Now, case 22 presents us with a patient with acanthosis nigricans.
Acanthosis nigricans is a skin condition characterized by velvety, dark patches of skin, usually found in body folds like the neck, armpits, and groin.
So what causes it?
It's often a sign of insulin resistance.
Insulin resistance. So we're talking about metabolic issues here.
Exactly, and examiners might ask about conditions associated with acanthosis nigricans, like type 2 diabetes, PCOS, and even certain cancers. They might also ask you to define metabolic syndrome.
So it can lead to a broader discussion about those metabolic risk factors.
It can. Now, case 23 gives us a gentleman with gout.
Gout. So we're thinking about those painful, swollen joints.
Right, but remember that chronic tophaceous gout might not always have that chalky material. Sometimes it just presents as simple swelling.
So we can't rely on seeing those classic tophis to make the diagnosis.
Exactly. So, what else should we consider when we examine a patient with suspected gout?
Well, we should probably check other joints for similar swelling. Right?
Absolutely. Look at the ears, the elbows, the hands, the Achilles tendon. You also want to be aware of tendon xanthomata as a potential differential diagnosis.
Tendon xanthomata, those are cholesterol deposits, aren't they?
They are. And finally, check the urine for hematuria and assess their kidney function. Gout and kidney problems can go hand in hand.
So many things to keep in mind with gout.
There are. Examiners might ask about things that can trigger gout attacks.
Like those rich foods and alcohol.
Yes, and they might ask about the best time to start treatment for hyperuricemia.
So they're testing your knowledge of both the acute and the chronic management of gout.
Exactly. They might even ask why patients with gout can have bilateral leg swelling, which is related to fluid overload from chronic kidney disease.
So again, it's about connecting the dots and understanding how different body systems are related.
You've got it. Now, for this particular gentleman, the conclusion is chronic tophaceous gout. And remember, uric acid crystals are negatively birefringent under polarized light.
So we're getting into the microscopic features now.
Sometimes those details are important for diagnosis. Now, case 24 isn't a specific patient scenario, but more like a set of helpful hints for diagnosis.
Okay, like what kind of hints?
Well, for instance, parotid swelling can be a sign of alcoholism.
Interesting.
Dupuytren's contracture can also suggest alcoholism. Skin hyperpigmentation can indicate hemochromatosis or iron overload, especially in thalassemia patients.
Well, I imagine that's more common in developing countries.
Yes, more likely to be seen there than in the UK. And tattoos or puncture wounds can suggest intravenous drug use and a possible hepatitis B infection.
Okay, so we're looking for clues that might reveal lifestyle factors or past medical history.
Exactly. Now, examiners often ask questions about liver disease.
Like what?
They might ask about Child-Pugh grading for liver disease. Remember the mnemonic pour another beer at 11?
Oh, yeah, that's a good one. What does it stand for again?
It stands for prothrombin time, ascites, bilirubin, albumin, and encephalopathy.
Got it.
And they might also ask about the complications of portal hypertension.
Okay, so it's important to have a good understanding of liver disease, its complications, and how to manage it. Now, case 25 takes us back to that idea of counseling and risk management. We're asked to see Dr. Henry, who accidentally pricked himself while taking blood from an HIV-positive patient.
Oh, that's a tough situation, especially for a new intern, as Dr. Henry is.
Definitely. So we need to explain post-exposure prophylaxis, or PEP, to him.
What?
Where do we start?
First, you need to assess his risk. Find out what he knows about the patient's status and ask about his own hepatitis B vaccination status. Also, find out about the HIV patient's status. Are they on treatment? What's their CD4 count? Any other medical problems? And of course, their hepatitis B and C status.
Okay, so we're gathering as much information as possible.
Right, and it's essential to reassure Dr. Henry that you're there to help. Explain PP to him in simple terms, including potential side effects, but don't overwhelm him with details at this stage.
Keep it calm and reassuring.
Exactly. And remember, examiners like to throw in those hidden agendas, so be ready for Dr. Henry to express concerns beyond just the needle stick.
Like what kind of concerns?
He might be worried about his recent marriage or his ability to work while he waits for the results. These cases often have an emotional component.
Okay, so be prepared to address those emotional needs as well. What else might the examiners ask about this case?
They might ask about the window period for HIV infection, the time it takes for the virus to show up on tests, or they might ask how you decide what treatment to offer Dr. Henry.
So they want to see if you can apply your knowledge to a real-life situation.
Right, and remember, PEP usually involves a combination of 3 antiretroviral drugs taken for 28 days.
Okay, now in case 26, we have a gentleman who is likely presenting with superior vena cava obstruction, or SVCO.
SVCO is a serious condition. The superior vena cava is a major vein that carries blood from the upper body back to the heart.
And when it's blocked, that's a big problem.
It is. What are some common exam questions they might ask about SVCO?
Well, I know they like to ask about Pemberton's sign.
Yes, that's a good one. It's a simple test for SVCO, and they might ask about perineoplastic syndromes.
Perineoplastic syndromes, those are those strange symptoms you can get with certain cancers.
That's right. SVCO can be a perineoplastic manifestation of some cancers, especially lung cancer.
So the SVCO could be the first clue that something more serious is going on.
Exactly. They might also ask you to name the different types of lung cancer or ask about contraindications for surgery for SVCO.
So they're testing your knowledge of lung cancer as well.
They are. Now, for this particular gentleman, the conclusion is that he has SVCO due to lung cancer. And it's important to remember that treatment for lung cancer depends on the type and stage.
Okay, so personalized treatment is key.
It is. Now, moving on to case 27. We have a lady who likely has chronic inflammatory demyelinating polyradicular neuropathy. That's quite a mouthful.
It is, but it's often shortened to CIDP. So what is CIDP?
CIDP is a rare neurological disorder that affects the peripheral nerves, causing weakness, numbness, tingling, and pain in the arms and legs. It's an autoimmune condition where the body attacks the myelin sheath, the protective covering around the nerves.
So it's a chronic condition that can really impact a person's mobility.
It can, and examiners often ask about the CSF findings in Guillain-Barré syndrome.
Guillain-Barré syndrome, that's another type of neuropathy, right?
It is. It's an acute form of inflammatory demyelinating polyradicular neuropathy, and they might ask about different types of hereditary motor sensory neuropathy, which are genetic.
Okay, so it's important to know how to differentiate between these different neuropathies.
Exactly. Now, in this case, the lady has CIDP, and she has muscle wasting because it's a chronic condition.
Muscle wasting can be really debilitating.
It can. Now, remember that you're unlikely to get a case of isolated ulnar, radial, or median nerve palsy in the MRCP PACES exam. The focus in PACES is on more complex neurological conditions.
Like CIDP.
Right. And for motor neuron disease, or MND, remember those 3 main clinical patterns: progressive muscular atrophy, bulbar palsy and amyotrophic lateral sclerosis.
ALS, that's the most common form of MND,
It
right?
is. Okay, case 28 gives us a gentleman who probably has Bell's palsy.
Bell's palsy, that's the condition that causes facial weakness, right?
That's right. It's thought to be caused by a virus that affects the facial nerve.
So how do we examine a patient with suspected Bell's palsy?
You need to test all the cranial nerves, starting with IX, X, and 12, which control swallowing, speaking, and tongue movement.
Okay, so we rule out any problems with those nerves.
Then you check cranial nerve 8 for hearing and cranial nerve X for shoulder movement. And don't forget to assess cranial nerve A for the sense of smell.
We're being thorough.
Always. Now, this patient's problem seems to be with facial expression and movement, so we want to focus on cranial nerves V and 7.
The trigeminal nerve and the facial nerve.
Exactly. And to distinguish between a lower motor neuron lesion and an upper motor neuron lesion, pay attention to the orbicularis oculi and frontalis muscles.
Okay, the muscles that control the eyelids and forehead.
Yes. In lower motor neuron lesions like Bell's palsy, both of these muscles are affected. But in upper motor neuron lesions, the frontalis muscle is often spared.
So the frontalis muscle can tell us a lot.
It can. Now, for this gentleman, the conclusion is right-sided Bell's palsy. And remember, the treatment usually involves steroids and a cyclovir.
Okay,
Specifically, this case is about pseudohypertrophy of the calf muscles.
pseudohypertrophy, meaning the muscles look big but are actually weak.
Exactly. It's a classic sign of certain types of muscular dystrophy.
So the respiratory exam is a bit of a distraction. We need to focus on the neurological exam.
Right. And while this might not be something you see every day in practice, it's a favorite for MRCP examiners, so be prepared.
Okay, so how do we approach this case?
First, carefully look for hypertrophy of both calf models. It's usually bilateral. Then when you examine the patient, see if they have a waddling gait. Check their muscle strength and note the pattern of weakness.
The pattern of weakness can tell us a lot.
It can. In muscular dystrophy, the proximal muscles, those closer to the body, are usually weaker than the distal muscles.
Okay, so that's a key feature.
And you might find the reflexes are normal, and there's no sensory loss, which helps rule out other conditions.
What else should we do?
After the neurological exam, demonstrate Gower's sign. This is a maneuver people with muscular dystrophy use to get up from the floor.
Oh, right, because of the weakness in their hip and thigh muscle.
Exactly. Also, examine the upper limbs, look for pseudohypertrophy of the deltoid muscle, and check for winging of the scapula.
So we're checking for involvement beyond just the legs.
We are. Ask about a family history because muscular dystrophy is often genetic. And look for surgical scars that might suggest a recent muscle biopsy.
We're building a complete picture here.
We are. For this gentleman, the conclusion is proximal myopathy due to Becker muscular dystrophy.
Becker muscular dystrophy, which is a less severe form than Duchenne muscular dystrophy.
Right. And the examiners might ask you to compare the two.
I bet they will.
They might also ask why we call it pseudohypertrophy. Remember, it's because the muscle enlargement is due to fat, not increased muscle mass. And they might ask about inheritance patterns and management, including genetic testing, muscle biopsy, and supportive care.
So it's a complex condition that requires a multidisciplinary approach.
Absolutely. And don't forget about genetic counseling, especially if the patient is thinking about having children.
Okay, case 30 focuses on pes cavus, another classic neurology case.
It is. And there are a couple of scenarios they might present.
Like what?
They might show a patient with pes cavus who also has cerebellar symptoms, like slurred speech and an unsteady gait.
So we're thinking about something affecting the cerebellum, the part of the brain that controls coordination.
Exactly. That would suggest Friedreich's ataxia, a rare genetic disorder.
Okay, what's another possible scenario?
They might show a patient with pes cavus and small muscle wasting in the hands, along with thin calves.
Okay, so a different pattern of weakness.
Right. That would suggest Charcot-Marie-Tooth disease, a group of inherited disorders that affect the peripheral nerves.
So two very different conditions that can both present with pes cavus. How do we tell them apart?
A thorough neurological exam is key. If you suspect Friedreich's ataxia, look for those cerebellar signs, ask about family history, and check for optic atrophy. If you suspect Charcot-Marie-Tooth, focus on signs of peripheral neuropathy and consider nerve conduction studies and genetic testing.
So the path we take depends on the clues we gather along the way.
Right. Now, the examiners might ask about inheritance patterns for these conditions, and they might ask about the underlying causes of pes cavus.
So we need to understand the genetics and the pathophysiology.
Exactly.
Yeah.
Okay, case 31 takes us into dermatology. It's about describing skin lesions.
Describing skin lesions accurately is a crucial skill for any doctor.
It is, and it's something they often test in the MRCP exam.
So how do we make sure our descriptions are clear and comprehensive?
Start with the general appearance. Is it a macule, a papule, a vesicle, or a bulla?
So we're categorizing the lesion based on its shape and whether it's flat or raised.
Right. Then describe the location. Face, trunk, limbs, mucous membranes. Is it symmetrical?
Okay, so we're providing a spatial context. What else?
Look for mucosal involvement and note any associated changes like itching, tenderness, nail pitting, or other signs. Don't forget to do a general inspection before focusing on the specific lesion.
Okay, so we're not just looking at the skin in isolation, we're considering the whole patient.
Exactly. And be prepared for questions about common skin conditions like Stevens-Johnson syndrome.
What is Stevens-Johnson syndrome?
It's a rare, serious disorder of the skin and mucous membranes. It's usually a reaction to medication or an infection.
And what's the difference between Stevens-Johnson syndrome and toxic epidermal necrolysis?
Toxic epidermal necrolysis is a more severe form of the same condition. They might also ask about specific medications that can cause skin reactions, like certain antibiotics or anti-seizure drugs.
Okay, so we need to know about those drug reactions.
You do. They might ask about management as well.
So how do you manage a drug-induced skin rash?
It depends on the severity, but generally it involves stopping the offending drug, providing supportive care, and in severe cases, using medications like corticosteroids or immunosuppressants.
Okay, that makes sense. Now, for this particular case, the conclusion is a macular-papular rash due to a drug allergy. And remember, you're not expected to be a dermatologist. A good description of the lesion is enough to pass the exam. That's reassuring. Okay, let's move on to case 32. This one involves a gentleman with xanthelasma.
Xanthelasma are those yellowish cholesterol deposits that you often see around the eyelids.
Right, they're a sign of hyperlipidemia, high cholesterol.
Exactly. And remember, hyperlipidemia is classified according to the Fredrickson classification system, which has types I through V.
So we need to be familiar with those different types of hyperlipidemia.
You do. What else should we consider when examining a patient with xanthelasma?
Well, we should look for other signs of hyperlipidemia, like those fatty deposits called xanthomas.
Good. And assess their risk factors for heart disease, like diabetes, high blood pressure, and smoking. Consider secondary causes of hyperlipidemia, such as nephrotic syndrome and hypothyroidism. And take a good family history, focusing on premature heart disease.
Okay, so we're thinking about those cardiovascular risks.
We are. And examiners might ask about managing hyperlipidemia. They might ask about different classes of drugs used to lower cholesterol.
Like statins.
Right. Make sure you're familiar with the major statin trials, like the 4S and MRCP trials, and know the common side effects of statins.
Okay, good advice. Now, for this particular gentleman, the conclusion is xanthelasma with underlying diabetes mellitus.
Right. So a reminder that these conditions often go hand in hand. Now, case 33 is interesting. We see a patient with a thoracotomy scar.
A thoracotomy scar, meaning they've had chest surgery.
Exactly. And this is a very popular question in the respiratory station of the MRCP exam. So what should we consider when we see a patient with a thoracotomy scar?
Well, it could be from a lobectomy or a pneumonectomy.
Good. Those are the two most common possibilities.
A lobectomy is the removal of a lobe of the lung, and a pneumonectomy is the removal of an entire lung.
Right.
So we need to figure out which procedure they had.
Exactly. And then we need to consider why they had the surgery.
Was it lung cancer, emphysema, tuberculosis?
Those are all possibilities. We need to ask about their past medical history, smoking history, and any other relevant symptoms.
Okay, so we're building a story about this patient's respiratory health.
Exactly. And we need to think about potential complications of the surgery as well.
Like what kind of complications?
Things like air leaks, infections, bleeding, and even chronic pain.
So it's a complex case that requires a thorough approach.
It is, right. And they might ask you about the reasons for doing a lobectomy or a pneumonectomy.
Okay, so what are some of the common indications for those procedures?
Well, a lobectomy might be done for things like lung cancer,
Okay.
or a localized infection, or a benign tumor. While a pneumonectomy is usually reserved for more extensive lung disease, like advanced lung cancer or severe bronchiectasis.
So the choice of procedure depends on the extent of the disease.
Exactly. Now, examiners might also ask about the potential complications of these surgeries.
Like what?
Well, some common complications include prolonged air leaks, infections, bleeding, and even chronic pain.
Those are all serious issues.
They are, so be prepared to discuss those potential complications.
Okay, so it's another case where we need to think about the procedure itself, the reasons behind it, and the potential long-term consequences.
It's all connected.
That wraps up our deep dive into these fascinating MRCP PACES cases. It's been a whirlwind of clinical challenges and exam tips. A huge thank you again to London HeartbeatsZ Academy UK for providing these insightful case studies.
They were really interesting.
And to all our listeners, don't forget to subscribe to our channels on Facebook, Instagram, Spotify, and YouTube for more deep dives like this one. We'll see you in our next deep dive.
Until next time.
Hey everyone, and welcome back. Today we're taking a deep dive into some pretty fascinating medical case studies. And we have London HeartbeatsZ Academy in the UK to thank for the awesome material they provided. It's like we're going to be playing medical detective, piecing together clues to figure out what's going on with these patients.
Sounds intriguing. I'm ready to put on my detective hat.
Awesome. So let's jump right in.
Yeah.
Imagine you're in the exam room and your first patient walks in. Right away, you notice their facial skin is really tight, almost stretched. And they have these little dilated blood vessels called telangiectasia. What are your initial thoughts?
Tight skin and telangiectasia. That combo instantly makes me think of systemic sclerosis.
Systemic sclerosis.
Mm-hmm.
Okay, so for our listeners who might not be familiar with that term, can you give us a quick breakdown?
Sure thing. Systemic sclerosis is a chronic autoimmune disease. What happens is the body's immune system starts attacking its own connective tissues, causing them to thicken and harden. That hardening is called sclerosis, and it can affect the skin blood vessels and even internal organs.
So it's not just skin deep then?
Nope. It's systemic, meaning it can impact multiple systems throughout the body.
Okay, that's helpful. So back to our patient with the tight skin and telangiectasia. If we're suspecting systemic sclerosis, what's our next move?
We need to conduct a thorough physical exam, starting with checking for dry eyes.
Dry eyes, what's the connection there?
Well, systemic sclerosis is often associated with another autoimmune condition called Sjogren's syndrome, which can cause dry eyes and mouth.
Ah, so we're looking for those little hints that might point us in the right direction.
Exactly. Next, we'd move on to examining the hands. We'd be looking for sclerodactyly, which is a thickening and tightening of the fingers. We'd also check for signs of Raynaud's phenomenon, which is where blood vessels in the fingers and toes spasm in response to cold or stress, causing them to turn white or blue.
So we're looking for changes in both the appearance and the function of the hands, What else?
We'd assess the extent of the skin involvement not just on the face, but on the rest of the body too. We'd also want to evaluate their hand function by having them do things like grip pinch and unbutton clothing.
It's like we're putting together a puzzle, gathering information from all these different parts of the body.
Precisely.
Yeah.
And of course, we can't forget about the patient's medical history. We need to ask about any difficulty swallowing, shortness of breath, or chronic diarrhea.
And why those specific symptoms?
Well, those could indicate involvement of the esophagus, lungs, or intestines, respectively.
It's amazing how one disease can have such diverse effects throughout the body.
It is. To wrap up our exam, we'd also need to listen to the patient's lungs, check their blood pressure, and assess for any signs of other organ involvement.
Now, let's say you're in an exam setting, and you're facing those examiners who are ready to grill you about systemic sclerosis. What kind of questions might they throw your way?
Oh, they'll definitely want to test your knowledge. They might ask about specific autoantibodies that are often present in systemic sclerosis, like ANA anticentromere and anti-topoisomerase antibodies.
Autoantibodies, I think a little refresher on those would be helpful for our listeners.
Sure, autoantibodies are basically proteins that are produced by the immune system, but instead of attacking foreign invaders, they mistakenly target the body's own tissues. In systemic sclerosis, certain autoantibodies are commonly found, so their presence can help confirm the diagnosis.
So it's like they're little flags that point towards systemic sclerosis.
Exactly. The examiners might also ask about prognostic factors, which are basically things that can influence how the disease progresses and how severe it becomes. Things like the patient's sex, the extent of skin involvement, and whether their kidneys are involved are all important prognostic factors in systemic sclerosis.
So they're not just looking for surface-level knowledge. They want to see that you really understand the nuances of the disease.
Right. They might also ask about the chronic diarrhea that some patients experience. This is often due to bacterial overgrowth in the small intestine, which can happen because of the changes that systemic sclerosis causes in the gut.
Okay, so we've got this complex picture of systemic sclerosis. What are some key takeaway points for our listeners to remember?
First and foremost, remember it's an autoimmune disease that affects connective tissues throughout the body. So pay attention to those skin changes, the hand involvement, and any multi-organ symptoms. Then remember those key autoantibodies and the prognostic factors.
Excellent advice. Now here's an extra tidbit for our listeners. Prednisolone, which is a common steroid, isn't actually effective in treating systemic sclerosis. Also remember that anemia in these patients can be caused by a variety of factors, including iron deficiency from chronic esophagitis malabsorption, anemia of chronic illness, and a more complex type called microangiopathic hemolytic anemia.
Those are great points to remember. It's all about connecting the dots and seeing the bigger picture.
Absolutely. Now let's shift gears a bit. Imagine you're examining a patient and you notice their fingers are clubbed, meaning they appear whiter and rounder at the tips. What comes to mind when you see this?
Clubbing in a respiratory exam is a significant finding, and it often makes me consider bronchiectasis.
Bronchiectasis. But wouldn't other lung problems like lung cancer cause clubbing too?
You're absolutely right. Other possibilities include lung cancer, suppurative lung diseases, and fibrosing alveolitis, but these conditions usually come with more severe symptoms and are less likely to be the main focus of an exam scenario.
So while clubbing is a red flag, it's important to consider the entire clinical picture.
Exactly.
Yeah.
Now, you might be thinking, how do I tell the difference between bronchiectasis and lung fibrosis, especially since both involve lung damage?
Yeah, that's a good question. They both sound pretty serious.
They can be. Think of it like this. Imagine two houses that need repair. One has leaky pipes and crumbling walls, making it practically unlivable. The other has some cracks but is still functioning. Bronchiectasis is like that first house. Patients are generally sicker and more prone to infections because their airways are so damaged. Lung fibrosis is more like the second house. The damage is there, but it might not be as immediately life-threatening.
I like that analogy.
Yeah.
So bronchiectasis patients are usually more ill because their lungs are in worse shape.
Precisely. And there are other key differences. The sounds you hear when you listen to their lungs are different. In bronchiectasis, you'll hear coarse crackles, and those sounds change when the patient coughs. Plus, bronchiectasis often involves lots of sputum production, so don't forget to check that sputum cup.
So the sounds in the sputum can help us differentiate. What about lung fibrosis? Any telltale signs there?
With lung fibrosis, you might see other clues that hint at an underlying cause. For example, they might have rheumatoid hands if they have rheumatoid arthritis, signs of systemic sclerosis, or even Cushingoid features if they've been on long-term steroid treatment. Checking their temperature chart is always a good idea, too.
So we're looking for those patterns and connections.
Right. Now, what kind of questions do you think the examiners might ask about this case?
Well, they might ask about the causes of bronchiectasis, which can range from infections to genetic conditions. They'd probably want to know how we would manage the condition, which I imagine involves medications, airway clearance techniques, and maybe surgery in some cases.
You're on the right track. And don't forget, they could also ask about other less common causes of clubbing just to test your broader knowledge.
So it's about showing them you've got a well-rounded understanding of the topic. Let's say in this case, the diagnosis is bronchiectasis due to a previous bout of tuberculosis.
That's a very plausible scenario.
And here's a key point for our listeners. Postural drainage is super important in managing bronchiectasis. It helps drain mucus from the lungs and improve breathing.
Absolutely. And keep in mind, if you ever encounter a patient with both bronchiectasis and dextrocardia, which is when the heart is on the right side of the chest instead of the left, think about Cardiganer's syndrome.
Cardiganer syndrome.
It's a rare genetic disorder that can cause both conditions. It's a bit of a medical zebra, but it's good to have it on your radar.
Okay, good to know. It's amazing how interconnected everything is in the body. Now let's move on to our next case. Picture this. You have a female patient with strikingly long fingers. What's your initial impression?
Long fingers, also known as arachnodactyly, are a hallmark sign of Marfan syndrome.
Marfan syndrome. Okay, so can you give us a bit more background on this condition?
In Marfan syndrome, there's a defect in a protein called fibrillin-1. This protein is essential for the strength and elasticity of connective tissues. And since connective tissues are found throughout the body, Marfan syndrome can have widespread effects.
So if that protein is faulty, it's like the body's scaffolding is weakened.
That's a great way to put it.
Okay, so we're suspecting Marfan syndrome. How do we confirm our suspicion?
We can do a couple of classic tests right there in the exam room. We can check for the thumb sign and the wrist sign. For the thumb sign, we have the patient make a fist. If their thumb extends beyond the edge of their hand, it's a positive sign. For the wrist sign, they wrap their thumb and pinky finger around their wrist. If the fingers overlap, it's another clue.
So those tests are all about assessing the length of the fingers relative to the hand. What else should we be looking for?
We'd examine the patient for other signs of Marfan syndrome, like a high-arched palate in the mouth, small papules on the neck, upward lens dislocation, in the eyes kyphoscoliosis, which is a curvature of the spine, and any chest wall deformities.
It sounds like Marfan syndrome can really impact the whole body from head to toe. Now, in an exam setting, what kind of questions might the examiners ask about Marfan syndrome?
They might want to know the specific diagnostic criteria we use to confirm Marfan syndrome. They might also ask about a condition called homocystinuria, which can cause similar skeletal abnormalities.
So they want to see that you can differentiate between conditions that might look similar on the surface.
Exactly. And they'll probably ask about the inheritance pattern of Marfan syndrome. It's an autosomal dominant condition, meaning if one parent has the gene, there's a 50% chance each of their children will inherit it.
So family history is a big piece of the puzzle.
It is. Now, let's say our lady does indeed have Marfan syndrome, and she also has mitral regurgitation, which means the mitral valve in her heart isn't closing properly.
Okay, so now we're seeing heart problems as well.
Yeah.
This brings up a really important point. Patient education and genetic counseling are absolutely essential when managing conditions like Marfan syndrome.
I couldn't agree more. Patients and their families need to understand what the condition means, the risks involved, and the available treatment options.
And for our listeners out there, remember, cardiovascular complications are the leading cause of death in Marfan syndrome. Early detection and careful monitoring are key.
Absolutely. Now on to case number 4. Imagine you're performing an abdominal exam on a male patient, and you notice he has gynecomastia, which means he has developed breast tissue. What's the first thing that pops into your head?
Well, I know gynecomastia can be caused by hormonal imbalances, certain medications, and some medical conditions, but in an abdominal exam setting, I'd definitely be thinking about liver problems.
You're spot on. Gynecomastia in this context is a strong indicator of chronic liver disease. It's a connection you should always make.
Chronic liver disease. Okay, so what other signs should we be looking for during our exam?
Be on the lookout for other stigmata of chronic liver disease. Things like clubbing of the fingers, Docre's contracture, which is a thickening and shortening of the tissues in the palmar erythema, which is redness of the palms, spider angiomas, flapping tremor of the hands, leukonychia or white nails, and any signs of jaundice, pallor pigmentation, cyanosis, xanthoma, purpura, koilonychia, paronychia, edema, muscle wasting tattoos, or needle marks.
Wow, that's a lot to keep in mind. It seems like every little detail matters when assessing liver health.
It does. The body often speaks to us in subtle ways. It's our job to listen and interpret those signs. Also, don't forget to consider their medication history because some common drugs like ketoconazole, spironolactone, H2 antagonists, and certain psychoactive meds can cause gynecomastia.
So we're thinking of medications as potential culprits, too. And remember, we also saw leukonychia in this gentleman, which makes me want to check for hepatosplenomegaly, meaning an enlargement of both the liver and spleen.
Good thinking. That's definitely something to consider.
Yeah.
And if you suspect ascites, which is fluid buildup in the abdomen, you could demonstrate the technique for checking for shifting dullness.
Can you walk us through that technique?
Sure. Shifting dullness is a physical exam technique where we percuss or tap on the abdomen in different positions to see if the areas of dullness shift as the patient's position changes. It's a classic sign of ascites. And remember, showmanship is important during exams, especially with examiners present. Always examine your patients systematically and project confidence.
Confidence is key. What are some questions the examiners might ask us about this case?
They might ask how you would investigate the patient further, what common things can trigger hepatic encephalopathy, where is a decline in brain function due to liver disease, how to diagnose spontaneous bacterial peritonitis, which is an infection of the fluid in the abdomen, and what your long-term plan would be for a patient with liver cirrhosis, which is scarring of the liver.
Sounds like they'll really put our knowledge of liver disease to the test.
They will. Now, for this case, let's say the diagnosis is chronic liver cirrhosis due to alcoholism.
That's certainly a possibility given the information we have. And here are a couple of extra points for our listeners. Be familiar with newer drugs for hepatitis B treatment besides interferon, such as lamivudine, adefovir, and entecavir.
Excellent additions.
It's important to stay up to date on the latest treatment options. Now let's revisit our Marfan syndrome case, the lady with the long fingers. This time we're going to focus on the cardiovascular aspects of her condition. Remember those handy thumb sign and wrist sign tests? They can really help solidify the diagnosis. But to be absolutely sure, we need to consider the major criteria as well.
Right, we're looking for involvement in multiple body systems, not just skeletal abnormalities.
Exactly. So what are those major criteria we should be aware of?
The major criteria for Marfan syndrome include ectopia lentis, which is an upward dislocation of the lens in the eye dilation of the aortic root, or aortic dissection, which is a tear in the wall of the aorta, and lumbosacral dural ectasia, which is an enlargement of the sac surrounding the spinal cord in the lower back.
So we're looking for problems in the eyes, the heart, and the spine. What role does family history play in diagnosing Marfan syndrome?
Family history is crucial. If a patient has a family history of Marfan syndrome, we only need to see involvement of two body systems to make the diagnosis. But without a family history, we need to see involvement of two systems plus one of those major criteria we just discussed.
So family history can either make the diagnosis more straightforward or more complex. What kind of questions might the examiners ask us about this case?
They might ask how you would manage Marfan syndrome, keeping in mind the importance of genetic counseling and patient education. They might also ask about the specific cardiovascular problems that are common in Marfan syndrome.
So they're looking for a comprehensive approach. And for our listeners, it's essential to remember that Marfan syndrome can have serious complications, especially those affecting the heart. Now, moving on to our next patient, we have a gentleman with multiple angiofibromas, also known as adenoma sebaceum, on his face. What does that finding make you think of?
Angiofibromas, especially when they appear on the face like that, are a hallmark sign of tuberous sclerosis complex.
Tuberous sclerosis complex. Okay, can you tell us a bit more about that condition?
Sure, it's a rare genetic disorder that causes non-cancerous tumors to grow in various parts of the body, including the brain, kidneys, heart, lungs, and skin. The severity can vary widely. Some people have mild symptoms, while others have more serious health problems.
So the severity is unpredictable. What other signs should we be looking for in this patient?
In addition to those angiofibromas on the face, we should examine the patient for other key features of tuberous sclerosis complex, like subungual or periungual fibromas. Those are growths around the fingernails and toenails. They can be easy to miss, so be thorough.
So we need to be meticulous with our skin exam.
Exactly. We should also look for hypopigmented macules, which are lighter patches of skin, and shagreen patches, which are areas of thickened dimpled skin. When examining for skin lesions, always expose the patient properly, and if time is limited, prioritize the patient's back as many lesions can appear there.
Okay, so we're not just looking at the face, we're examining the whole body. What about exams beyond the skin?
We should definitely consider further exams, like a fundus exam to check for retinal hamartomas, which are benign tumors in the eyes, and an abdominal exam to feel for a palatable kidney, which can occur due to renal hamartomas.
So tuberous sclerosis complex can affect the eyes and kidneys as well.
It can. Don't forget to take a complete family history asking about similar problems, and ask about any history of epilepsy because seizures are common in tuberous sclerosis complex.
Okay, so we're taking a holistic approach considering family history and potential neurological involvement.
Right. Now, here's something candidates often miss: testing the patient's IQ and looking for side effects of anti-epileptic medications, particularly phenytoin.
Why is IQ testing important in this context? And what kind of side effects are we looking for with phenytoin?
Intellectual disability is common in tuberous sclerosis complex, so assessing cognitive function is essential. As for phenytoin, it can cause cerebellar signs which affect coordination and balance gum hypertrophy, which means the gums become overgrown, and hirsutism, which is excessive hair growth.
So we're thinking about the impact of both the condition itself and the potential side effects of its treatments. What kind of question then might the examiners ask about this case?
They might ask about common findings on a CT scan of the brain in a patient with tuberous sclerosis complex, like cortical tumors,
Mm.
and they'll probably want to know how you would manage the patient overall.
So it's about showing a comprehensive understanding of the condition and its management. In this case, we can conclude that the gentleman does have tuberous sclerosis complex. And for our listeners, remember, this condition is caused by mutations in either of two genes, TSC1 or TSC2.
Excellent point. And it's worth noting that only one of those genes needs to be mutated for the condition to show up.
So a single genetic error can have cascading effects throughout the body. Now let's put ourselves in the shoes of an SHO in charge of a medical unit. Imagine you have a patient, an XIV drug user, who was admitted for shortness of breath. Their chest X-ray showed bilateral haziness, and the consultant suspects pneumocystis jirovecii pneumonia. The patient is responding well to treatment, but now you need to have a delicate conversation with him about HIV testing.
Pretest counseling for HIV is always challenging, especially in an exam setting where you're being observed.
It definitely requires sensitivity and skill.
Mm.
Where do we even begin?
Before you jump into the specifics of HIV, start by assessing the patient's understanding of their current condition and their expectations. You could say something like, "Mr. Smith, I learned that you were admitted to our hospital about a week ago. Did anyone tell you what's wrong?"
So we're starting by meeting the patient where they're at and understanding their baseline knowledge.
Exactly. Then briefly explain their diagnosis and how the treatment is helping. You could say you have something called pneumocystis jirovecii pneumonia, which is a type of lung infection, but the good news is you're feeling better after the treatment.
Okay, so we've set the stage and provided some reassurance. Now, how do we bring up HIV?
Gently introduce HIV as a possible cause of pneumocystis jirovecii pneumonia, especially in people with certain risk factors. You could ask, "Do you know anything about HIV?" Or, "Are you familiar with HIV/AIDS?"
So we're gauging their level of understanding and opening the door for further discussion.
Right. Once you've assessed their knowledge, you can provide more information about HIV, explaining what it is, how it's transmitted, the potential long-term complications, and the available treatments.
Mhm.
And it's important to get their sexual and social history during this conversation.
So we're giving them the information they need to make an informed decision.
Based on their history and your explanation, you can then assess their risk of HIV infection and explain why testing is important. You could say, "Based on what you've told me, I think you're at risk of having HIV. That's why I think it's important for you to get tested."
Okay, we've established the need for testing. What's next?
Explain the testing process, detailing how the test is performed, how to interpret positive and negative results, and the possibility of false results. And be sure to differentiate between being HIV positive and having AIDS.
So we're addressing any anxieties they might have about the testing process.
Exactly. You also want to convince them of the benefits of early detection. Emphasize that the test results are confidential, and if appropriate, discuss the potential implications of a positive result on things like insurance.
Those are practical considerations that patients often worry about.
They are, and before wrapping up, let the patient know about additional support and resources. You can say something like, "If you have any questions or concerns, we have a specially trained nurse here who can provide more information and support. Would you like to meet with her?"
So we're not just leaving them to figure this out on their own. We're connecting them with resources.
Right. And finally, arrange the next appointment, but be prepared if they're hesitant about the test. Always ask for their reasons if they decline.
It's about respect and open communication. What kind of curveball questions might the examiners throw at us about this case?
They might ask about the window period, which is the time between potential exposure to HIV and when it becomes detectable in a test.
So they're testing our knowledge of the specifics of HIV testing.
Yes, they want to see that you understand the nuances. Okay, now let's move on to a different case. Imagine you're examining a patient and you notice they have irregular pale patches of skin. What condition comes to mind?
Irregular pale patches of skin.
Sounds like vitiligo.
Vitiligo is a chronic skin condition where the skin loses its pigment, resulting in those pale patches.
And what causes those patches to lose their pigment? The exact cause is still unclear, but it's thought to be an autoimmune disorder where the body's immune system attacks the melanocytes, which are the cells that produce melanin, the pigment that gives our skin color.
So another case of the immune system going rogue. I know recognizing vitiligo is usually pretty straightforward, but you always emphasize going beyond just recognizing a condition. What else should we be doing?
You're right. It's a common exam finding, and most candidates can diagnose it just by looking. But examiners want to see that you can go beyond just recognition. They want to see a systematic approach that shows you understand its presentation and potential associations.
Okay, so how do we approach this exam systematically?
Remember this phrase, hypopigmented patches with white hairs in the affected area. Begin by looking for those patches in common areas like around the mouth, eyes, armpits, and limbs.
So there's a typical pattern of involvement.
Yes. And don't just focus on the skin. Examine the patient's scalp for white hair and any signs of alopecia areata, which is an autoimmune condition that causes patchy hair loss. Vitiligo and alopecia areata can occur together.
So we're considering other autoimmune conditions that might be present.
Exactly. You should also look for signs of jaundice, which could point to autoimmune hepatitis pallor, which might indicate pernicious anemia, and thyroid swelling, which could suggest autoimmune thyroid disease.
It's like a domino effect. One autoimmune condition can lead to others.
Right. You should also suggest checking for a postural drop in blood pressure, which could indicate Addison's disease, and checking their blood pressure for diabetes mellitus. And, of course, be on the lookout for other autoimmune diseases like rheumatoid arthritis and systemic lupus erythematosus.
So we're taking a comprehensive approach.
Exactly. Now, I know you're thinking there are other conditions that can cause hypopigmented skin. How do we differentiate vitiligo from those?
You read my mind. So how do we tell them apart?
Conditions like leprosy and pityriasis versicolor can also cause hypopigmented skin, but the patches are usually more localized. If you suspect leprosy, you should check for reduced sensation in the affected area.
Okay, so sensation testing can help us rule out other conditions. What about treatment for vitiligo?
There are various treatments available. Topical steroids can be helpful early on. Topical immunomodulators like calcipotriene and tacrolimus are options too, and often combinations of therapies work best. For example, combining calcipotriol with PUVA therapy or using tacrolimus with laser therapy can be effective.
So there are multiple avenues to explore. What kind of questions do you think examiners would ask about this case?
They'd likely want to know about the conditions associated with vitiligo and how you would manage the patient.
So they're looking for a well-rounded understanding. So in this case, our patient likely has vitiligo. And for our listeners, remember that about 20–25% of people with vitiligo also have other skin or systemic diseases associated with it. Now let's move on to a case involving a lady with chronic defacious gout. What should we focus on here?
The key is to immediately recognize the characteristic features of chronic defacious gout, like the presence of tophi, which are deposits of uric acid crystals that can form under the skin, around joints, and in other tissues.
And what kind of questions should we anticipate from the examiners?
They might ask about how to diagnose gout, including the clinical criteria and necessary investigations. They might also ask about the mechanisms that lead to kidney problems in gout patients.
So they're testing our understanding of both diagnosis and complications.
Yes. Specifically, they might ask about obstructive uropathy, where the flow of urine from the kidneys is blocked, and NSAID abuse, as those drugs can contribute to kidney problems in some gout patients.
Okay, so it's about connecting the dots and understanding the potential long-term consequences. In this case, we can conclude that the lady does indeed have chronic defacious gout. Now let's shift to a more challenging scenario. Imagine you're the SHO in charge of the ICU, and you have to tell a mother that her son is brain dead and discuss organ donation.
This is a tough one. It's a common scenario in the MRCP PACES exam, and candidates often find it difficult to explain brain death to family members, which makes it even harder to discuss organ donation.
It's understandable that those two conversations would be closely intertwined.
Absolutely. Start by assessing the mother's understanding of her son's condition and what her expectations are. Ask her something like, Mrs. Lee, I know that your son was admitted to our hospital 3 days ago. Did anyone inform you about his condition? And you can also inquire about her expectations. Did you visit your son in the ICU this morning? What do you think about his condition compared to when he was admitted?
So we're trying to gauge her level of awareness and her emotional state.
Right. You need to approach this with empathy and sensitivity. If she believes her son's condition is improving, you may need to spend more time explaining the details, like the CT scan reports and other tests, to gently prepare her for the difficult news.
It's about finding that balance between honesty and compassion.
Exactly. Now, how do we deliver the news about brain death? After gauging her response and providing some context, you can gently break the bad news. Say something like, "Mrs. Lee, I'm afraid that your son is brain dead." Give her time to process this and avoid overwhelming her with technical details.
Clarity, empathy, and patience are crucial.
Absolutely. It's
Mhm.
important to anticipate that Mrs. Lee might not be able to accept that her son is gone. Empathize with her, validate her feelings, and never rush or pressure her to accept this difficult news.
It's about being present with her in her grief and allowing her to process this at her own pace. Now, if she doesn't accept that her son is dead, how do we even bring up organ donation?
You're right, it's a delicate balance. This is where exploring the patient's social history can be invaluable. It can help you find a way to gently steer the conversation towards organ donation. For example, if you learned that Mr. Lee was an only child, you could gently introduce the idea that even in death, he could help others.
So we're using her understanding of her son's character to bridge the gap to organ donation.
Precisely. Once she seems receptive, you can inquire about her prior knowledge of organ donation. Ask, have you heard of organ donation before?
That opens the door for further discussion.
Yes, and once the mother is receptive to the idea, you can delve into the specifics of organ donation.
Okay, so we've navigated that difficult conversation. Now on to our next case. We have a lady presenting with a right claw hand. What does this tell us neurologically?
A claw hand, especially when it's just one hand, is a classic sign of ulnar nerve palsy.
Ulnar nerve palsy.
Got it.
But we'd want to figure out what caused the nerve palsy, wouldn't we?
Of course. In this case, let's say you notice a scar on the patient's wrist.
A scar. That suggests previous trauma, maybe an industrial injury.
That's very possible.
So the scar gives us a valuable clue. Now let's talk anatomy. Remind us which muscles the ulnar nerve supplies.
The ulnar nerve supplies all the small muscles of the hand except oloaf, which stands for the lateral two lumbricals, opponens pollicis, abductor pollicis brevis, and flexor pollicis brevis.
Olbaf, that's a helpful mnemonic. How does that relate to the claw hand we're seeing?
Well, the lumbricals help flex the metacarpophalangeal joints and extend the interphalangeal joints of all fingers except the thumb. So the claw hand in this case only involves the ring and little fingers. That's because the lateral two lumbricals, which control the index and middle fingers, are supplied by the median nerve, not the ulnar nerve.
So the specific pattern of the claw hand tells us which nerve is affected.
Exactly. Now let's delve a bit deeper into the anatomy of the ulnar nerve as it travels into the hand.
Okay, walk us through it.
The ulnar nerve enters the palm just in front of the flexor retinaculum. It runs alongside the lateral border of the pisiform bone. Then it divides into two branches, a superficial branch and a deep branch.
Two branches, got it.
Well,
What do those branches do?
the superficial branch provides sensation to the palm side of the little finger and the adjacent side of the ring finger. It also has a branch that supplies the palmaris brevis, a small muscle in the palm. The deep branch supplies most of the other small muscles of the hand.
So the ulnar nerve is responsible for both sensation and muscle function in the hand. What's a good way to demonstrate the effects of ulnar nerve palsy to the examiners?
You can demonstrate from and sign. Ask the patient to grasp a piece of paper between their thumb and the side of their index finger with each hand.
It's like a little strength test.
Exactly. If they have ulnar nerve palsy, the affected thumb will flex because the adductor pollicis muscle is weak. That flexion is actually the action of the flexor pollicis brevis, which is supplied by the median nerve.
Fascinating. So the body compensates for the weakness in one muscle by using another. What kind of questions do you think the examiners might ask about this case?
They might ask about the ulnar nerve paradox, which describes how sometimes a high ulnar nerve injury can cause less hand muscle weakness than a low ulnar nerve injury. It seems counterintuitive, but it has to do with the specific muscles affected at different levels.
Good to know. They might also ask us to repeat which small muscles of the hand are not supplied by the ulnar nerve.
Right, they want to make sure you understand the details. So to sum up, Our Lady has, right, ulnar nerve palsy, likely due to a previous trauma, which we know because of the scar. And for an extra point, remember that the superficial branch of the ulnar nerve also has a muscular branch that supplies the palmaris brevis.
Excellent summary.
Hmm.
Okay, let's move on to what some might consider a gift in the MRCP PACES exam, a case of acromegaly. Why is it considered a gift?
Acromegaly often has very obvious physical signs, making it relatively easy to diagnose.
So it's a case where the visual clues are pretty clear. Yeah. But we still need to be systematic, right? How would you examine a suspected case of acromegaly?
Absolutely. Start with a general inspection, just taking in the patient's overall appearance, then examine their hands. You'll likely notice a spade-like sweaty hand with thick, doughy skin. Also check for carpal tunnel syndrome, which is common in acromegaly.
So the hands can tell it's a lot right away. What about the face?
Examine the face carefully, looking for prognathism, which is a protruding jaw that can cause the teeth to be misaligned. Also look for prominent supraorbital ridges, widely spaced teeth, and a large tongue.
It's amazing how the effects of acromegaly are visible in so many different features. What else should we examine?
You could offer to look for skin tags at the armpit, then examine the lower limbs for pitting edema, which could suggest heart failure.
So we're thinking about how acromegaly might be affecting other systems.
Yes. Next, check for proximal myopathy, which is muscle weakness, by asking the patient to squat down. And check for bitemporal hemianopia, which is a type of vision loss. This is important because acromegaly is often due to a pituitary macroadenoma, which is a tumor that can press on the optic chiasm and affect vision.
So we're considering the underlying cause as well.
Absolutely. After demonstrating those positive signs, you can suggest to the examiners that you'd like to complete the physical exam by checking blood pressure, which can indicate active disease. Also, checking their urine for sugar or blood, which could point to diabetes or kidney stones. And you could suggest examining the back of the eye and comparing the patient's current appearance with old photos.
That sounds like a very thorough examination.
It is. With acromegaly, there's a lot to consider. Now, what kind of questions do you think examiners might ask?
They might ask about what indicates that the acromegaly is active and progressing.
Good question. Indicators for disease activity include uncontrolled symptoms like headaches, sweating skin tags, uncontrolled diabetes, high blood pressure, and progressive vision problems. It's essential to share your thoughts about disease activity with the examiners, showing them that you're thinking about the bigger picture.
So demonstrating that you can connect the dots.
Exactly. They might also ask about how to investigate the patient further.
What kind of investigations would be most helpful?
The most important test is checking if growth hormone levels are still high after the patient drinks a sugary drink. That's called an oral glucose tolerance test. Normally, glucose would suppress growth hormone, but in acromegaly, it doesn't.
Interesting. So it's a specific test for the hormonal imbalance in acromegaly. In this case, we can say the lady has acromegaly caused by a pituitary macroadenoma like we suspected.
Good deduction. And remember, those signs of active disease, uncontrolled symptoms, high blood pressure, vision problems, always point those out to the examiners.
All right, we've covered acromegaly. Let's move on. Now imagine we're the SHO talking to a female patient named Miss Sylvia who's been admitted to the ward. What's important to remember when discussing a patient's illness?
Always start by figuring out how much the patient already knows about their illness. You can start by saying something like, Miss Sylvia, I'm the SHO in charge of this ward. How are you feeling today? And then, I know you were admitted because of reason for admission. Did anyone explain what's going on?
So we're gauging their knowledge level before we jump in.
Exactly. Then you can tailor your explanation to their understanding. Some patients might already know a lot, so you can have a more detailed discussion. Others might need more basic information.
Okay, so we're personalizing the approach. Now, in this case, Miss Sylvia is a woman. What special things do we need to consider when dealing with female patients, especially with a condition like epilepsy?
Always think about how the disease and its treatment might affect pregnancy and breastfeeding. It's really important to discuss these things because they can have a big impact on a woman's life.
Absolutely. We have to be sensitive to those concerns.
Unfortunately, some candidates forget about these social aspects. I remember a case where a candidate failed because they missed these points. The patient didn't want to take her epilepsy medication because she was worried about getting pregnant. The candidate didn't ask about her support system. She didn't have much help at home. They also ignored her concerns about passing on epilepsy to her baby and her questions about abortion.
That's a great example of how ignoring those social factors can lead to problems. Even if it's not directly in the exam instructions, addressing the patient's concerns is crucial for good care.
Exactly. Okay, let's switch gears. We have a gentleman with some serious spinal problems.
What's his posture like?
He has a question mark posture. It's caused by fixed kyphoscoliosis in the thoracic spine, and his neck is extended to compensate. Basically, his body is trying to balance out the spinal deformities.
So it's a visually striking presentation.
Yeah.
But you said this case can be tricky in the MRCP PACES exam, right?
Yes, because if the patient is lying down, the kyphosis might be hidden by the pillow. You have to be really observant.
Okay, so pay close attention to the details. What other symptom is important?
He's had chronic back pain since he was 20 years old.
Chronic back pain, that's a big clue.
Right. It points towards ankylosing spondylitis, which is a type of inflammatory arthritis that mainly affects the spine.
Ankylosing spondylitis. How should we examine him?
First, watch him walk away, turn around and walk back. Then check how well he can move his neck. See if he has trouble turning his head and has to move his whole body.
So we're looking for limited range of motion.
Right. Next, check his thoracic and lumbar spine movement. Ask him to bend sideways, rotate, bend forward and backward while you hold his pelvis still to isolate the spine movement.
We're testing the flexibility of his spine. Are there any special tests we should do for the examiners?
Yes, 2 specific tests. The occiput to wall test. Have the patient stand with their back against the wall and try to touch their head to it. People with ankylosing spondylitis can't do this easily because their spine is stiff.
It's a simple way to show the impact of the condition.
The second test is Schober's test.
How do we do that one?
Make 2 marks on the patient's back. One 10 centimeters above and one 5 centimeters below the dimple of Venus, which is that little indentation on the lower back.
Okay, so we've got our reference points.
Now have the patient bend forward as far as they can and measure the distance between the marks. Normally, it should increase by at least 5 centimeters. But in ankylosing spondylitis, the increase will be less because the spine is stiff.
So Schober's test gives us a measurement of spinal flexibility. What kind of questions should we expect about ankylosing spondylitis?
Examiners will probably ask about the diagnostic criteria, like the modified New York criteria, which includes limited spinal motion pain history and limited chest expansion. They'll also ask about management, don't forget to mention genetic counseling, and HLA-B27, which is a gene strongly linked to ankylosing spondylitis.
So we need to cover the diagnosis, the genetics, and the overall management plan. In this case, we can say the gentleman has ankylosing spondylitis with limited spine movement.
Good. And remember those New York criteria, limited lumbar spine motion in all planes pain history, and limited chest expansion to less than an inch. Those are the key points.
Is there an algorithm to help diagnose ankylosing spondylitis?
Yes. Start by checking if the patient has low back pain that's worse in the morning or at night and gets better with NSAID pain relievers.
So that helps narrow things down.
From there, you can do more tests like a pelvic x-ray and an HLA-B27 test to confirm the diagnosis.
Okay, that algorithm is helpful.
Yep.
Let's switch gears again. Imagine you're the SHO and you're talking to a woman named Miss Sylvia who was recently admitted. What's important to remember?
Before you start explaining anything, figure out what she already knows. Ask